Now we're going to move from concept to practice. Our next speakers are going to talk about setting up an obesity clinic. For the chairpersons, I would like to call upon Dr. Divya Ragate and Dr. Rashmi KG, both of whom we've just met. Dr. Rashmi again is consultant endocrinologist at Manipal Hospital, Bengaluru, and Dr. Divya ma'am is a consultant endocrinologist at Aster CMI Hospital, Bengaluru.
For the next session on setting up an obesity clinic, I would like to call Dr. Mahesh, consultant endocrinologist at Aster CMI Hospital. Welcome, sir. And, and I would also like to call Dr. Basavaraj GS, consultant endocrinologist at Narayana Health, Bangalore. Sir will be joining in sometime. Mahesh sir will start. Over to you, sir.
Good afternoon, dear friends. It's an honor and pleasure to be here with Disha team. And Disha always takes a new direction. And every year there is something new and innovative. And today, me and Dr. Basavaraj will be talking about the model obesity clinic. So we are divided into three parts. One, where I will talk about what is to be done in an obesity clinic. And then Dr. Basavaraj will talk about why we need a dedicated obesity clinic and how to actually establish it, what should be think when we do it, and then we'll summarize what is to be done for a patient who comes to us with obesity. So we all are well aware of the global burden, and then we'll be looking at the design, the treatment integration, and monitoring outcomes, because monitoring quality indicators is one of the most important aspects of our care. Because if we want to progress, we have to know who is responding, who is not responding. Then only we will be able to make new progress and take new strides and to see what are the gaps in our therapy, so that we can bridge them through either the next generation molecules or in fact focusing more on lifestyle and behavioral aspects. So the global burden of diabetes has gone up significantly. 1 in 8 people have obesity by 2022, and that has gone up significantly. And the rate of doubling is almost, every 20 years it almost doubles. And there is a need for establishing guidelines and also following measures that not just treat these patients but also reverse the obesity direction in which we are traveling. In Indian context, the obesity is not just rising in the urban population where we actually see a huge number, but in the semi-urban and rural areas it has gone up almost 8 to 9 times compared to what it was 20 years back. And there is a need for not just looking at doctors as a mode of addressing this, but also improve the healthcare support system or the government infrastructure which looks at nutrition, because nutrition is not just what we eat at home, it's what is available everywhere wherever we go. So let us understand obesity. Obesity is a very complex disease where we usually focus only on the energy imbalance. 90% of us or 100% of us will think that it is energy imbalance, and maybe 5%, 3% will think okay, of genetics may play a part. Otherwise, most of the people think that even ಸ್ವಲ್ಪ ಜಾಸ್ತಿನೇ ತಿಂತಾ ಇರಬೇಕು, ಟೈಮಿಗೆ ಸರಿಯಾಗಿ ತಿನ್ನಲ್ಲ. That is what everybody will think. And nobody understands that it is a biology that changes as the weight increases due to many factors, that not just is focused on the energy intake. Energy intake is definitely the most significant and important aspect. But if we just think that by reducing energy intake everything will solve, we will not be able to reach the appropriate goal, and finally we fail to talk to the patient, because patient is trying to say ಎಷ್ಟೊಂದು ಜನ ಹೇಳ್ತಾರೆ ಸರ್ ನಾನು ವೆಯ್ಟ್ ಲಾಸ್ ಎಷ್ಟು ಟ್ರೈ ಮಾಡ್ತಾ ಇದ್ರೆ ಏನೂ ಆಗ್ತಾ ಇಲ್ಲ, ನಾನು ಏನೇ ಮಾಡಿದ್ರು ಐ ಆಮ್ ನಾಟ್ ಏಬಲ್ ಟು ಲೂಸ್ ವೇಟ್, ಐ ಹವ್ ಡನ್ ಎವ್ರಿಥಿಂಗ್ ಬಟ್ ಸ್ಟಿಲ್ ಐ ನಾಟ್ ವೇಟ್ ಇಸ್ ನಾಟ್ ಕಮಿಂಗ್ ಡೌನ್. ಆ್ಯಂಡ್ ವಿ ಸೇ ದಟ್ ಇಲ್ಲ ಇನ್ನೂ ಟ್ರೈ ಮಾಡಿ, ಇನ್ನೂ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಎಫರ್ಟ್ ಆಗಿ ನೀವು ಆಗ್ತಾ ಇರೋದು ಸಾಲಲ್ಲ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ವಿ ಜಸ್ಟ್ ಟೆಲ್ ದೆಮ್ ಟು ಡೂ ಮೋರ್, send them to the dietitian without understanding the biology or explaining to them the biology. So there is not just energy imbalance, followed by which there is a gut adipose tissue brain axis that changes, where dysregulation of hormones occurs, and this dysregulation of hormones will persist in a way that it is very difficult to reverse it just by eating less. And definitely polygenetic, epigenetic influences and many of the food factors, the obesogenic factors that the patient may consume with taking some stored food or this ultra processed food and processed food, which are all the numbers that you can see. If you see any number in any packet, E126, F358, all those whatever numbers are there, they are all obesogenic because they slow down the metabolism and make you more hungry, feel hungry. So adipose tissue is not just a storage organ, it is an endocrine organ which produces leptin, adiponectin resistance, and whenever there is obesity, there is decrease in adiponectin and increase in leptin and leptin resistance, which followed systemic inflammation that occurs because of the abdominal obesity, and then there is a change in the gut microbiota which influences the adipocyte balance and inflammation, and together there is an adipocyte dysfunction. It is not just storage excess, it is the adipocyte dysfunction that occurs. So therefore the word for obesity now is ABCD, easy to remember, adiposity based chronic disease, that is ABCD. So just to show you here, so first there is a change in the amount of fat, then there is a change in the function of the fat, and then there is a redistribution and distribution. Because of this you have two problems. One is a fat mass disease, which is predominantly the weight related problems that you can use osteoarthritis and obstetritis pediatria as on the body images as one of the examples. And then there is a sick fat disease where there is changes in the inflammation, immune system and the deranged endocrine organ, where there is large amount of fat deposited in the areas where we usually don't see fat, especially tachycardial, pericardial, retroperitoneal, or mental relationship fat, which leads to inflammation, and this inflammation with insulin resistance is responsible for all the problems that we see in our clinic, and they can be divided into metabolic problems, which we are well aware of, including the fatty liver, diabetes and dyslipidemia, and the cardiovascular complications, hypertension, heart failure, thrombotic risk, atrial fibrillation, stroke and DVT and pulmonary thromboembolism. Further, it is not just looking at the metabolic and physical impact on the patient, but we also have to look at the mechanical and emotional impact. Some of the patient tells, sir, ನಾನು ಮದುವೆನಲ್ಲಿ ತೊಗೊಂಡಿದ್ದ ಡ್ರೆಸ್ಸು ನಾನು ಒಂದು ವರ್ಷ ಆದಮೇಲೆ ತೊಗೊಂಡಿದ್ದ ಡ್ರೆಸ್ ಆನಿವರ್ಸರಿಗೆ ಅದನ್ನು ಫೈನಲಿ ಹಾಕೊಳ್ಳೋಕ್ಕಾಗ್ತಾ ಇದೆ. ಐ ಆಮ್ ಲುಕಿಂಗ್ ಮೋರ್ ನೈಸ್ ನೌ ದ್ಯಾನ್ ವಾಟ್ ಐ ಯೂಸ್ ಟು ಲುಕ್ ಅರ್ಲಿಯರ್. It gives them a sense of self-confidence. Wearing the dress makes me more confident is what some of the patients tell when they lose weight. And I have found that to be one of the most important marker of how they feel. We may tell him sugar kammi aayto, BP kammi aayto, everything. But they feel that if they are able to fit into one dress that they really like, they felt good, that makes a huge psychological impact on them. So I keep dress as the most important criteria of patient satisfaction, apart from doctor satisfaction of the values. Doctor is satisfied with sugar values, BP values, all the values. We look at the report, we are very happy. But how can the patient be happy with it? Patient may feel that comfortable, that's all. But happiness is a state of mind. That is possible only when they fit into a dress which they were not able to fit. Like for example, I am wearing my marriage pant. So I am very happy that I am wearing my marriage pant reception because I was not able to fit into this 2 years back. So finally I am also happy that I am able to fit into this pant. So which is one of the important criteria of feeling good. Not only feeling comfortable is a sign of values, but feeling good is how you actually look at yourself in the mirror and how the dress gives you a feeling. So we are all looking beyond the metabolic diseases where PCOS, depression, osteoarthritis, obesity, all are part of the same spectrum of obesity. So whenever we want to ask a patient how we usually do, we briefly go through the phases. The first phase is contemplation, where you try to understand the patient. You don't try to look at what you think is right or wrong or do all the assessment. You contemplation is the process of understanding the patient. Then assessment is looking at the doctor related issues that you want to find out. Then we look at the diagnosis staging. Then we discuss the treatment goals. And then once it is done, we always look at continuity because it's a chronic problem. If it's not a 6-month, 3-month fix that you can achieve just by taking a drug, patient loses weight in 6 months, he stops. Most of it comes back in 1 to 2 years. So we need to classify the patients into 2 groups. Stage 1 obesity, where there is no diseases. So we don't look at pharmacotherapy as the main option. But stage 2 is where we want to look at the pharmacotherapy and lifestyle measures as very important, where patient may have diseases or limitations which we need to We have to tell the patient, show that the changes that happen are not only related to your weight, but there is also change in the hormones, metabolism, which are affected by the stress and sleep. And genetics plays a role where you can have problems related to three M's, that is the metabolic health, mechanical health, and the mental health. So you just say M, write in your prescription and tick that which is more important for the patient and try to address them as you treat them in the process, which deserves support, understanding, and personalized plan, and not just blame and shame. So most of the people ask, why is it so difficult to lose weight? I am doing my best, but still I am not able to maintain weight. And some people say, I'm just not able to control my hunger, and there is always food noise that comes to me. So this can be addressed through lifestyle measures and combination with pharmacotherapy. We will be able to achieve addressing this. So once the patient starts eating well, they gain weight, or they eat normally, if they alter sleep and stress, they gain weight. What happens is after a period of time, usually 1 to 2 years, it becomes very difficult to lose weight. And if you don't eat, the body knows that you are not eating. So it's very difficult to fool the body. You can fool anybody on earth, but you cannot fool the body. If you don't eat, the body knows you are not eating. So after some time, it will understand that the body weight has a thermostat. Like a thermostat, there is a weight stat which is there in the body. So the body is able to fix that is my new weight, and it doesn't allow it to come back. So the weight gain, the metabolism, hunger hormones, and fullness hormones change in such a way. It's always a struggle, and this struggle, most people who are trying to lose weight really know how difficult it is. And they give up, and that is what happens, this problem. First time they lose weight, they regain very fast. Second time they take very long time to lose weight, they regain that in a very short period of time. Third time they try to lose, but they stop, and then they go up. Somebody was telling me it's 85 kg, now it is 110, and they were 60 when they got married. So you have to really wonder what is happening. It's because the combination of age, time of food intake, sleep, stress, calorie dense food versus nutrient dense food makes a huge impact in this journey of the patient, where they are trying to lose weight, but there is some resistance, and that resistance is both combined by the doctor and the patient psychological factors. So same thing we need to understand when we see a patient, do the screening BMI, anthropometric measurement, clinical measurement, take medical history, and that medical history should be comprehensive. So we will make this available to you easily in the last QR code. So this will include the total medical assessment, then the history, surgical history, weight trajectory, eating phenotype, whether they have hungry brain, hungry drug, or they eat emotionally, psychological evaluation, and do all the tests, if required genetic tests, do referral, and do blood tests and other tests that require to give comprehensive assessment of the patient. Then we have to set realistic goal, understand that 5 to 10% weight loss over 6 months is our main goal, and this has shown benefit, and this is the picture we need to show our patient, that the percentage weight reduction. So I want you to lose 10%, 5% because you have 1, 2, 3, 4 problems. If we show this, the patient understands what the doctor wants. But remember, what the patient wants may not be same. So we need to understand what the patient wants also, along with our medical goals. So this is a simple way in which we can start our evaluation and process of deciding about what is the combination of therapies that we need. So if the BMI is less than 27, we focus mainly on the nutrition and physical activity with behavioral therapy. If it is more than 27, definitely this is required, plus medicines when there is complication. BMI is more than 30, that is more than enough to consider the weight loss medicines. And if it's 35 and above and not responding to medicines, then consider the surgical protocol. So this is lifestyle intervention, where we talk about modifications, where calorie deficit is required, change in the meal structure, portion control, food restrictions. All four should be there to achieve the nutrition balance, where the metabolism shifts from being storative to explorative or exhaustive, that is more in terms of burning the calories. And start with daily walking, then stretching, moderate activity, sleep tracking, step tracking is important. We need to reach at least 7 to 12,000 steps in order to achieve good weight maintenance. So the weight trajectory is important, dietary flattening, sleep, and medication review all help in understanding what is the reason for weight gain and how the trajectory has been. And physical examination, we do all the necessary examination, including the assessment, and both the standing and BP measurements, standing and sitting measurements of BP is also important, and look at dermatological signs or other problems. Then the metabolic problems, screening, endocrine screening, risk stratification. Then we need to create personalized care plan, where there is a setting of the SMART goal, that is specific, measurable, achievable, relevant, time-bound weight loss targets, and shared decision making, assess readiness, and schedule reviews, so that we do all this in a methodical way. So we assess the patient and escalate or de-escalate the medications as we start the treatment plan. So finally, before we talk about how to establish a clinic, we'll go through briefly the principles of nutritional therapy. Calorie deficit of 500 to 750 calories, targeting zero point 0.5 to 1 kg weight loss per week. Increasing the protein intake from usually zero point 0.5 to zero point 0.7 is what most of us consume, especially vegetarians. It has to go up to 1 gram to 1.2 and even up to 1.5 gram as we process in this journey. Otherwise, we will have sarcopenic obesity. From moving the patient from obesity to sarcopenic obesity will keep the metabolic problems intact without any meaningful goals in the end. Mediterranean diet and dash pattern of diet with a lot of vegetables and fruits and nuts will help, and consider meal replacement whenever necessary. Physical activity prescription is something that we need to talk to the patient, because it is not a one step of doing 30 minutes walking. It will not end in that. We need to talk about 150 minutes per week. We need to also tell resistance training, and most important, ಮನೆಯಲ್ಲಿ ಒಂದು ಪಾತ್ರೆ ತೊಳೆಯೋದು, ನಿಮ್ಮ ಬೆಡ್ಶೀಟ್ ಮುಚ್ಚೋದು ಆರ್ ಆಲ್ ಇಂಪಾರ್ಟೆಂಟ್. ಕೆಳಗಡೆ ಏನೋ ಹಾಲು ಬಂದಿರುತ್ತೆ, ಹೋಗಿ ತೊಗೊಂಡು ಬರೋದು, all those small steps that is neat is very, very important in ensuring that you are active throughout the day. If you are active, there will be some metabolism that is going on, so that your body is thinking of not just storing but also utilizing the energy that is stored. And giving work to the soleus muscle will make a huge difference, because it will reduce the amount of fat deposition inside the muscle, and your muscle will be an active organ rather than a passive organ of storing the fat and losing its ability to actually give you the energy. So this is a simple picture that we can show to our patient. It's a 7-day planner. You see, ಮಳೆ ಬರ್ತಾ ಸರ್ ಆಚೆ ಹೋಗಕ್ಕಾಗಲ್ಲ. So this is where you can show brisk walking outside and spot marking. Like we are standing here, we can just move our legs. You can also move your legs, give some exercise to your soleus muscle, because you are sitting here for more than 1 hour. So a little bit of movement of your soleus muscle will make an impact on your health also. So you can move your soleus muscles, 10 steps when you sit for every half an hour will make some difference. So you can do a lot of things. Dancing is also something that you can do at home. Keep the music light. So now this is there, so you can take this home, and you and your wife or partners can dance at home wearing this and listening to the music, as an easy method of burning your calories along with doing some core body strength exercises. So finally, behavioral support is also as important, because we have to understand the patient, which we fail to do because lack of time is the most important reason. So if you give a good assessment for the patient, give a sheet where they fill up all their problems, then it becomes easy to talk to them about that. Then the time required for you may be just 3 or 4 minutes rather than 10 minutes giving support. That makes a huge impact. That is very important for relapse prevention, where unless and until we address this relapse prevention, we will fail in our endeavor to reach the goal of obesity related diseases and reducing them in our day-to-day practice. With this, I invite my dear friend Dr. Basavaraj to talk about why all this can be done in a very dedicated obesity clinic, and he is one of the best person to talk about this.
Yeah, I think audible, perfect. You can sit here. So you have put up so many of questions for us. So okay, you can lie to anyone except your body, not to your wife for sure. And dancing with wife, life keeps us dancing. ಮತ್ತೆ dance ಮಾಡೋದು ಅಲ್ಲ, with the same spouse. Divya smiling. ಅಲ್ಲ, right? Okay. So I think everyone has giggled a little bit, and then now we'll move on. Okay. Now let's see how many of you are wanting to treat obesity. Yes, show of hands. Good numbers. Very good. Very good. Very nice. So I think we have got a very good focused crowd of how you wanted to treat obesity. You want to treat obesity, and what has to be done here for obesity, treating obesity, and what's the most ideal obesity clinic. So this is what we are going to talk is about the model obesity clinic. Why a dedicated obesity clinic? Definitely this is not possible in our day-to-day routine clinic. Then what adjustments can be done, we'll go forward and move and see. But then again, a setup, an institutional setup like a medical colleges or a tertiary referral center, having a dedicated obesity clinic always helps, because there are some of these And these centers also serve as platforms for clinical trials, medical education, and community outreach, advancing the entire field of obesity medicine there. So, what should be the vision and mission of such a kind of a hospital? So, first is compassionate care. So, deliver stigma-free, patient-centered obesity care that respects individual journeys and challenges. So, that's very important. Okay, so then again, that also means about the communication also. Okay, we'll come to that. Integrated approach, it should have a preventive, lifestyle, pharmacotherapy, and surgical, all involved into personalized treatment plans, and then probably, if possible, good research modalities also. So first, prior than the physical infrastructure, what we have to understand is about the language. Language, not just about the doctor, language of your front desk, language of the educator, and language of everyone. Okay, so when you are communicating, so someone is sitting outside and someone comes and tells, sir, avunu dummukkidana avunu banda sir. So that itself is a very, very grossly what stigmatizing language. Correct? Okay, gundukkidane, dummukkidane, or heavy agidare, avuru. So you have to address always with the name of the patient. Number one. Number two, never ever discuss any of these patient related matters in terms when you have another patient or anyone else is sitting there. If it's a healthcare professional, we understand, then we can discuss with the name of the patient. If a third party or a patient or even industry people is also there, never ever discuss about the patients there. So sensitizing all of your staffs about these things. You might not be calling that patient as a Duma, but the patient who would have been seen next, definitely, who is waiting for a next consultation, would definitely know that you would definitely call out her or him also in a similar language. So these sensitivities, small things, are very important. Now coming to the physical infrastructure. Okay, just look at your chairs where you are sitting. Okay, perfect. How many of you think a morbid obesity patient can sit in this? No, not a lot of them. Correct? Absolutely correct. The chairs have got good handles, but definitely good obese patients who got BMI of more than 35 or so, they will never be able to sit in this. Now, I had a patient who came to me for treatment. I remember his name also. That's what changed my whole story. This is individual learning, and then we moved on. BMI was 38. Okay, and then there was this slightly bigger chairs, or slightly heavier built chairs for were there in our clinic. So those who have visited my clinic, these are the brown chairs which we used to use initially. And then what happened was this patient was trying to fit into the chair. Hitkondo serkoladadrali. But then again, I just made a comment. Can you please use the couch? Or there was a bed besides. He felt annoyed and he felt so bad that he made sure that he fit into that somehow. So that these are all the small things which we have to understand. So post that, I got a custom made chair with the widest possible this thing, 28 inches or 30 inches is the width, where I have like a normal patient comes also, then there can be easily a mother and a child sitting there. So there they sit comfortably, and then that whole conversation starts. So now they understand that the doctor understands my pain points. So that's one. Third point, your door size also, that matters. Okay, a lot of times these are quite heavy, and sometimes our doors are so, because of the scarcity of space, we tend to keep it very small. Then what happens is patients have to struggle, keep moving around. So keep bigger door sizes so that they can walk freely. So that one patient goes, one patient comes parallelly also, they can move forward. Okay, if you have a clinic like mine in first floor, then definitely a provision of lift is essential. If not for lift, then definitely you give double handrails. Handrails is a must. Without handrails, do not ask them to climb any floor. Okay, then that will be something what iatrogenic fracture which will be causing or something like that. So double handrails like both the sides, correct? So both the sides if you can provide. So these double handrails are important. And these wide-based couches, dedicated spaces, making them feel a little bit more comfortable and not stigmatized is very important. And then how many of you have got this? The width doesn't matter. It does matter. Sorry, it is not the only thing. But then you have to see that they can hold weights up to 180 to 200 kg. What's your maximum weight you have seen in your clinic? 140s? Yes, 160s? I have seen 194. Okay, so such is the scale of obesity. So wherein again, it's not just about the chair; it's also about your weighing scale. Weighing scale, most of the weighing scales, have you checked till what weight it goes? 140, mostly, correct? And sometimes they don't even tell regularly also. So probably making sure that you are actually getting those weighing scales which are bariatric purpose. Even the stadiometers, I've seen, so they've got these thin plastic placed platforms to stand on. So all these things have to be modified, have to be made sure that they can handle these 200 kgs of weight. Now just understand, yes, blood pressure cuff, very correct, sir. Blood pressure cuff, the routine blood pressure cuffs also don't work. You'll have to get the XLL. I've got 2 cups in my clinic for that, and these work with the Omron machines which we use routinely. So just you will have to find out and get these double XL sort of blood pressure cups there. So now please understand, a patient comes, stands, and if your weighing machine does not show up, just comes and stops at 140, how much offended or how much of problem he feels psychologically. So that is something which we guys all have to be responsible. Try to see what all best things can be done. All of these things needs to be done. Your toilets again. See toilets again. All the Western toilets. It will be difficult for them to get up from that. So giving a handrail which helps them to get up from that also helps. Small things which are necessary for the physical infrastructure. Then again, going forward, we have to have some decent referral patterns at least for the core endocrinologist as the lead. Then we have to have a dietitian and a nutritionist, physiotherapist, clinical psychologist, nurse educator, and a bariatric specialist. And then definitely some of these other uh, extended specialist network is also there. So when we look at these patients, then the patient pathway should be have to be referred to the obesity clinic, have to be assessed for the complications and other things. Try to talk to them, talk about the treatment expectations, treatment, and then we have to follow them. So referral criteria for endocrinologists would be BMI more than 27 with at least one obesity and more than 30, regardless of the comorbidity status. These are all the good indications of treatment. And then the clinical indicators are 3 to 6 months of lifestyle interventions over 3 to 6 months, patient preference for structured multidisciplinary program, and rapid weight gain or medication-induced weight gains are all there. So the lifestyle changes, pharmacotherapy, and surgical weight management, all of them have to be discussed with the patient there. Pharmacotherapy overview, so these things you'll have to look at. So basically you got your semaglutide, which has been approved up to 2.4 milligram once a week, dual agonist. So basically tirzepatide achieves up to 22% of weight loss. Orlistat, not so commonly used, naltrexone and bupropion, very rarely used if at all in a clinic. Then we have got hierarchies of the preferred medications for complication-centric care of the people. Look at the comorbidities of the patients. So definitely what Dr. Mahesh did tell is that we keep talking about the psychiatric illnesses worsening. What if the depression is because of the obesity itself? Then patients definitely have seen a lot of patients who are feeling better after taking these anti-obesity medications, and they feel that they're one of their life's most toughest of the challenges taken care of, then I can deal with anything and everything in it. So that is the kind of confidence which these patients get, and then these help in overall long term. But definitely comorbidities include your MASH, MASLD, osteoarthritis, your OSA, your ACVD risk. Okay, so all of these things definitely help in the choice of the drug therapy which you have taken. Okay, lifestyle recommendation in conjunction with interventions for weight management have to be there. So you remember this thing whenever patients come and talk about, doctor, what do you want me to know about obesity or anti-obesity medication? I have acronymized this as HELP. HELP. H stands for hydration. E stands for exercises. L stands for low carb, low fat, low calorie basically, and P stands for protein, high protein. So that will be very catchy and very easy for the patient to remember the acronym. Acronym is, okay, shall we do a little Bhagavat here so that we make some noise so that the other all hears? But no, not wanted now. So probably help. Okay, hydration, exercises, low carb, low fat, and protein. Always remember, help. Okay, so those things to minimize the side effects, start low and increase the dose gradually every week once. I strictly follow this, though people measure has some other algorithms, but then I strictly follow this once a week, right? Once a week doses every month, and then for 3 months I go straight without stopping unless they are super responders who lose more than 5% weight loss in a month, or where side effects make us stop or slow down us. Until then, we don't sort of look at least until 7.5. I hit it 7.5 and then wait, because the real anti-obesity actions of tirzepatide start at 7.5, with semaglutide starts at 1 milligram. So I usually push it up to there and then keep it going. Slow titration, hydration, avoid fizzy drinks, regular small meals, avoid outside food, low fat diet and low spicy diet, not much of spicy diet. They can take a BPI a day before, on that day, a day after, 2 to 3 days. I usually prefer to give it in the weekends. So Fridays, Thursdays and Fridays are my hardcore obesity OPD. And one day if I take Friday off, my Saturday is screwed. Everyone is jumping. Doctor and dose it, doctor and dose it, miss Saitota. So now I am sort of trapped in my own in my own net, that everyone, if I cannot take a holiday on Friday or Saturday now. So then again I'm trying to spread it out across the week, but let's see how it goes. So yes, eat small, stay hydrated, engage in 15 to 20 minutes of resistance exercises almost on a daily basis. Do not do not eat heavy meals. 80% full is good. So you have to make up your proteins, egg whites, fishes, chicken, sprouts, dal, milk curd, buttermilk. Any of these things are good. Predominantly rely on this. If at all, if it's not sufficient, then probably go for additional added proteins in your meal. 1 gram is a must. Though many guidelines tell to push up to 1.5 grams, but it is very, very difficult. How many of you have had taken at least 1/3 of your daily requirement of protein in since morning? I haven't. ಬೆಳಗ್ಗೆ 2 ವಡೆ ತಿಂದಿದ್ದೀನಿ, 2 ಕಪ್ ಕಾಫಿ, ಅಲ್ಲಿ 2 ಕಪ್ ಕಾಫಿ, ಒಂದು ಪೂಜೆ ಜೊತೆಲಿ, ಒಂದು ಮಹೇಶ ಜೊತೆಲಿ 3-4 ಕಪ್ ಕಾಫಿನೇ ಆಗಿದೆ. ಓಕೆ, ಇಟ್ ಈಸ್ ಶುಗರ್, ಮಿಲ್ಕ್, ವಾಟರ್ ಆ್ಯಂಡ್ ವಡೆ ಅಂದರೆ ಎಣ್ಣೆ, ಸ್ವಲ್ಪ ಬೇಳೆ. ಸೊ just imagine, Indians are very poor at protein. So talking is very easy. Touching even 1 gram is very difficult. So for us to touch, for me, 72 kgs guy, 70 grams of protein means I am eating daily 2 eggs, a big bowl of dal in the afternoon, in the night, 500 ml of milk or buttermilk. This gets me 60 grams of protein only. I am still deficient by 10 grams. Where else I can add? Okay, so probably it has to be a protein dense meal. At least 1 gram is the target which we give, and which we keep making them eat these things. Monitor nutrition, correct all the deficiencies. One of the most commonest deficiency which is usually ignored is iron, ferritin. We usually look at vitamin D and B12, but definitely start looking at ferritin. Treat the ferritin. You usually tend to say, doctor ಏನಂದ ಅಯ್ಯೋ ಹೋಯ್ತು ಎಲ್ಲ ಕೂದಲೆಲ್ಲ ಹೋಯ್ತು ಬಿದ್ದೋಯ್ತು, all of that. This is not because of that, but yes, okay, we shaved it because of some ritual. But then again, what? So treating ferritin to a good level of 50 is what makes the hair fall incidence also come. We usually treat D and B12 in a good way, good protein supplementation. And we all know the drugs which are there. Semaglutide is there. Then we have got tirzepatide. So titrate slowly. Renal functions, be careful and use it very carefully in these patients. Lipid panel, monitor the lipid panel and be careful in patients with diabetes while using a hypoglycemic drug like with your insulin or sulfonylurea. Be very careful and try to treat it in a very judicious way. Bariatric and metabolic surgery for BMI more than 40 or BMI more than 30. I think bariatric surgery will also go obsolete once we have the GGG molecules, the retatrutide, GLP, GIP and the glucagon agonist. Retatrutide. So probably they have touched up to 30% of weight loss. So then the bariatric surgery and other things might not be as important as in the current context. Then we have to look at the nutritional assessment. Psychological readiness is also important. Some people tell, 2 ತಿಂಗಳು ತಗೊಂಡು ನೋಡ್ತೀನಿ ಆಗುತ್ತಾ? So how many of you agree for that? 2 ತಿಂಗಳು ತಗೊಂಡು ನೋಡ್ತೀನಿ. It's a long-term disease, number one. I tell, usually it's for at least for 6 to 12 months to begin with. Not less than 6 months, because 3 months is required for titration. 3 months is required at least for seeing the effects of the drug. 6 months is the bare minimum. A a lot of these IVF fertilities have specialists have been sending a lot of patients. ಒಂದು 3 ತಿಂಗಳು ತಗೊಂಡು ವೇಟ್ ರಿಡ್ಯೂಸ್ ಮಾಡ್ಕೊಂಡು ಬನ್ನಿ ಆಗಲ್ವೇ I tell them very clearly ಆಗಲ್ಲ. But then again we have demonstrated some of these beautiful examples for these infertility specialists where people have lost 15 to 18% of it, definitely with anti-obesity medications, so that now they are convinced, a couple of them are convinced that they have to take it for 6 months. ಆವಾಗ ಅವ್ರು ಏನು ಮಾಡ್ತಾರೆ, because there is always fear of the patient getting away. So what they do is they enroll on their fertility programs and then they send us. ಆಯ್ತು ಏನಾದರೂ ಮಾಡಿಕೊಡ್ರಿ, ಬಟ್ ದೆನ್ ಅಗೇನ್ ವಿ ಆರ್ ಪ್ರಾಬಬ್ಲಿ ಫಾರ್ ದ ಬೆನಿಫಿಟ್ ಆಫ್ ದ ಪೇಷಂಟ್ we treat them and then we start working up them and then try to give the best control. Post-operative and other things, pediatric and adolescent obesity, rising problem. We have got certain of the molecules which have been approved for the usage in pediatric and adolescent obesity, including liraglutide and semaglutide for obesity. PCOS and fertility, a lot of patients with PCOS and fertility aspects are there who see us for weight loss management. And preconception optimization, that was I was speaking. And then gestational weight gain, probably I have not had much experience with this, but encouraging a good lifestyle will definitely help you. Okay, if at all you have these things, it's very well and good. App-based tracking, we have got our WhatsApp body chatbot which keeps a track of these questions. We have got our diabetes educator, obesity educator, and a dietitian also who follows these questions on certain programs. Wearable technology if required, but typically your step count, which can be done with a small smartphone also helps here, and virtual group visits which are taken care by our obesity educator and dietitian so that they stay motivated and continuously good. Okay, challenges and pitfalls for discussion. Weight regain we have to talk about. We have to definitely talk about the weight regain, that if you stop the medications and without lifestyle modifications you are going to gain back the weight. So that has to be the communication. So maintaining good lifestyle modifications definitely helps them maintain weight. Not much of them gain weight. I've seen typically 5% weight gain after losing 15 to 20% weight gain. Weight loss they have gained probably in 6 months 3 to 5%, not much. But then again there can be biases in my observations. I'm open to discuss on that. But then again you have to understand about the therapeutic inertia. You have to understand about the non-responders. Semaglutide has got good 30% non-responders, whereas tirzepatide has got 3 to 4% non-responders. Across clinical trials this has been proven. So be careful about this thing. Don't over-promise. Okay, don't over-promise. Don't under-deliver. So set right with the expectations. I think that is important. Cost and access is definitely we have to discuss with the patient. Someone who buys 1 or 2 months of tirzepatide and tells me I'm not going to continue this doesn't make sense at all. Rather give a try of semaglutide and tell we'll go for 6 months and then see if at all if you don't lose then we'll discuss further. Social stigma, a lot of my patients, not lot, but probably 2 to 3% of my patients come to clinic and take the drugs. Because at home they cannot take the medication because people feel that it's a stigma of taking the injection. So we have got nice labeling mechanisms in our fridge where we label those drugs and keep it, hoping as of now though there's nothing of confusion that some patient has taken up someone else's or nothing. So we don't know, this is a potential problem which we are anticipating, but we'll see how we can solve that problem by telling that. But we tell patients that there will be a lot of patients other things. So what they do is they go pick up their dose, come and cross check with one of our staff that this is my dose, correct. Only when they agree then they take it to our clinic. Okay, so future directions in obesity medicine, very eagerly waiting is your orforglipron and cagricima trials are also out. So we might get to see all of these newer medications for obesity. Retatrutide probably in a couple of years further. Next gen incretins your retatrutide. US FDA issued warnings on the unapproved compounded GLP-1. I think recently Indian guidelines also, Indian government authorities have also probably warned or given notifications for strict approval of usage within the clinically meaningful guidelines or recommendations. And then probably microbiome and gene editings are also quite important. So chronic disease recognition, obesity is a chronic disease. You have to convey and communicate to the patient in a similar way. Multidisciplinary is preferred whenever for these patients who are difficult to treat. Early pharmacotherapy is considered. Surgical considerations are also there. So for this I'll give it up to Dr. Mahesh DM. So one thing, so what's your take when a patient tells ki doctor ನಾನು walking diet ಮಾಡಿ ಮಾಡ್ಕೊಂತೀನಿ? How do you convince them? Anyone has some something. I give a lot of examples. So, okay, one of my most beautiful example is, so someone who is coming from North India. Yesterday I had a patient from Kota. I remember this example. Okay, so you want to walk till Kota, and if you want to go to Kota, how do you prefer to go? Will you be able to walk and go? Patient is puzzled. Ayo, identa question. Will you be able to walk and go? Simple question. Yes, maybe Athara answer there. So only simple explanation here is, yes, you can walk, but it needs a lot of training, it needs a lot of focus, it needs a lot of energy, resources, everything for you to walk till Kota or some distant place. Correct? The same way, if at all you book a cab or a car or some bus which helps you go towards Kota, and from there you can walk to your village. Is that not possible? So this is what is the role done by your anti-obesity medications rather than replacing your walking and exercises. And we have to be very clear that lifestyle modifications are always the cornerstone. They'll never be compromised, or they'll never be singled out, or they'll never be thrown out of the room. So they are the center stage. Over and above that, we are adding the anti-obesity medications for betterment, or don't use the word quicker, faster. All of these things are taken in a very random way, or you can tell easier or a predictable weight loss. These are the kind of words which are actually weighed very well and taken very well by educated patients who understand English. This last slide, Dr. Mahesh will take up.
Thank you, Dr. Basavaraj, for an enlightening talk on model obesity clinic. So after the patient has undergone all the therapies, or you told everything, but like Dr. Basavaraj said, there are some who don't respond. Their response may not be there in terms of weight loss. The response may not be there in terms of the metabolic problems that they have. Patient says, sir, ನೀವು ಡಾಕ್ಟರ್ ವೆಯ್ಟ್ ಲಾಸ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಶುಗರ್ ಎಲ್ಲ ಇಂಪ್ರೂವ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ನಾನು ವೆಯ್ಟ್ ಲಾಸ್ ಆಯಿತು ಬಟ್ ನನ್ನ ಶುಗರ್ ಅಷ್ಟೇ ಇದೆ. ದಟ್ ಈಸ್ ವಾಟ್ ದ ಪೇಷಂಟ್ ವಿಲ್ ಟೆಲ್. So we need to understand that this process of completing the evaluation ends only after re-evaluation and restaging that occurs after 3 to 6 months of therapy. That is when your real consultation is over, and that process is where we need to look at the various other etiologies that could be there, review of the medications, look at medical conditions that can be there associated, look at any genetic or syndromic cause, we may require some genetic testing, where there is any internalized psychological disorder that we missed in the first step, and definitely look at the social determinants, and also see whether in the family related there is any other issue, so that you can restage and evaluate them. So this is just to summarize what journey looks like. Contemplation, initial assessment, diagnosis, staging, treatment goals is what we all do, but it is possible to maintain that only if we follow the last step, that is care and continuity, where there is a way in which we can follow them up either digitally or when the patient comes to us, so that we keep a track. See, your weight journey is like this, it is moving in the right direction, so we are very happy in your progress. So I sometimes write good, you are very well done. So the patient feels it's like a marks card that the patient has received, and patient has a smile on his face. That is what made me write it more often. Very good, excellent, as the patient shows improvement in their progress. So this is just to finally show you a pictorial way. There is initial diagnosis, then the foundation lifestyle is always there. Whether the patient is going through any therapy, this foundation lifestyle includes diet and nutrition, but also sometimes behavioral therapy. Sleep is very, very important. Sleeping for minimum 6 hours is very, very important. Without 6 hours sleep, it is very difficult to have good metabolic health. And then this has to undergo a 2-year plan where you actually achieve the goal and maintain that. Then only you can say your consultation is complete in one way, that you achieved all the goals of evaluation, staging, and care and therapy. So to simplify the way in which you can give a patient a form in the OPD, we have together put up this scan. So this is a patient assessment sheet. If you want, we'll share it with you in the group also. This is a QR code you can give to the patient, you can download in your clinic, and then it's a PDF form which you can take a print and give to the patient. It tries to cover all the evaluation that needs to be done of the patient, including their family, including the emotional aspect of the stress-related issue, and whether they are interested in taking the drug or not. Sometimes I spend 1 hour and the patient says, sir, ನನಗೆ ಮಾತ್ರೆ ಏನು ಬೇಕಿಲ್ಲ, ನನಗೆ ವೆಯ್ಟ್ ಲಾಸ್ ನೀವು ಹೆಂಗೆ ಹೇಳ್ತೀರಾ ಅಂತ ನೋಡೋಕೆ ಬಂದಿದೆ ಅಷ್ಟೇ ಅಂತ ಹೇಳ್ತಾರೆ patient. Then I think that's why now I decided to add the last question. Are you ready it goes on for 1 hour, then it becomes very difficult. Then there is, in the end, there is no. I have found that if the consultation process half an hour, then neither the doctor benefits nor the patient benefits. So that is not. It's not a lecture series that we want with the patient. So a 15 to 20 minute good evaluation with a comprehensive form makes a huge difference in how we feel. So we'll be happy to take some questions. Thank you.
Yeah, I think a couple of those things we were not able to put this in the slides. So, how many of you have indemnity insurances? Yes, perfect. Okay, so double that up if you are treating obesity. Okay, that's rule number one. Okay, so that's one. Second thing is I had written some of the points. I don't know where I've lost it. So the other thing is discussing with the patients is again important. So you'll have to spend some good amount of time. Okay, 15 to 20 patients initially, and giving them a good overview of all the side effects and other things. A good way what we do is what Banu has developed. Banu, raise your hand, please. Banu has developed. He has helped us develop. So in our website, a good questionnaire and good understanding FAQs of the side effects of the semaglutide and other things. I just paste it in the EMR and then send them for the first time and then ask them to come back. Third thing is comorbidity handling. Psychiatry diseases, be very clear that they do not have any major depressive illnesses, major psychiatric illnesses. Okay, so all of these things you have to be very clear and careful. Suicidal tendencies which are there. And a couple of those things I had written. Discussing with the patient again becomes very important because then they might come back and tell, doctor, agila. Semaglutide ಬಂದ್ಮೇಲೆ you have to very clearly tell that this has got a 30% non-response rate. ಅದು ಹೇಳಿದ್ರೆ then you are sort of out from your thing. ನಾನು ಹೇಳಿದ್ದೆ ಇದು ಆಯ್ತು ನೋಡೋಣ ಬಿಡು ಅಂತ then you can move on. Then I think should be okay. Then how many of you feel that such kind of topics needs to be discussed a lot? Still more? Definitely. Okay. December 6th, we have got our end obesity meeting at Ritz-Carlton. We do it every year. So this is primarily focused only on obesity. We keep talking there and those things. Yes, I got the message. You got to have an educator or a dietitian. Illa antande your WhatsApp keeps buzzing. Doctor, I have had bad nausea. Doctor, I have had diarrhea. Doctor, elidira anta. Okay, so you have to have an educator for the initial at least a month who can handle them and try to teach them these things are there. IP referral is important. So you have to have some situations. Suddenly you get registered call ki, doctor, I have had 30 dysenteries till now. It is not stopping. I want to get admitted. If you have standalone OPD unit, then you are stuck. Okay, then again, then there is your reputation at stake. How, what, where, if you just send randomly. So you have to have some nice IP referrals where things are taken care of. Okay, fundus checking is what I have written. So people with diabetes and obesity, please check a fundus and note before starting any of these medications. Comorbidity screening in terms of psychiatry to even hair fall, what they are all worried of. So these things I think you will have to keep working on them. Any questions? We are open to take. Yes, sir. Please.
I think if patient misses the dose, how do we?
So if the patient misses the dose most of the time, up to 3 to 4 days, there is no problem. We can take, for example, the patient is taken on Friday, he can take up to the next Monday if he misses the next Friday. But if it is Tuesday or Wednesday, it is better to start on the Friday again. One dose missing, nothing will happen.
Multiple doses means again.
Yeah, multiple doses. If they miss, please don't start with the higher dose because I have seen one patient who was taking 0.25 for 1 month and then he took 0.5 one dose and stopped, went outside India or whatever, came back and took 0.5 directly and he had side effects. 3 patients had side effects. So please go back to the previous dose only that unless they were on the dose for more than 3 months or 6 months, when they took the break, then probably you can start with the previous dose. But whenever they have taken a break before uptight routine, let them start again with the previous dose. It's better to have less weight loss, less side effects than more side effects and more weight loss.
Regarding patient having NPDR, mild we can start or moderate and severe?
Yeah, mild to moderate we usually start. Severe NPDR and PDS we usually very cautious when taking of these stands. Strictly sit with them and discuss about all of the worsening of the diabetic retinopathy and those things are need to be discussed before starting on that.
Regarding gallstone disease.
I'm okay with starting on gallstone disease unless they've had a gallstone pancreatitis or cholecystitis. I'm okay with starting. Okay, people differ on this, but we do not have a statement of what to do with this. Okay, now gallstone disease with obesity is taken an indication for cholecystectomy. So that's not true. Please don't do that. So probably a lot of patients I've seen typically who are coming from Andhra and all of that. So they've had their cholecystectomy and then started anti-obesity medication. So
Yeah, if see the gallstone is very tricky because the number of gallstones and the size also has an indirect impact on the smaller the stone, the chances it passes through is low. So those patients gallbladder split have a higher risk of developing either cholecystitis or pancreatitis. So I always tell go to the surgeon, let them talk and come back, and if they decide to whether they want to get the surgery, then it is up to them to get the surgery.
the caveat here is the gallstones are also because of obesity. Okay, so then it's the chicken versus the hen. Oh, okay, the egg versus the chicken, which came first? Wala funda comes in. So yes, it's again open to debate.
We have no evidence that weight loss will reduce the gallstones.
Gallstones, correct.
That is why we need to give the patient the option. You tell as a doctor, I am okay to start if you are ready.
Divya, what do you do?
Keep the surgeon in the loop, sir.
It's okay because see one pancreatitis will stop the entire option of obesity treatment. So anyhow they will spend 2 to 3 lakhs for 2 to 3 years. Okay, most of them have insurance covered for gallbladder. Otherwise I tell them 2 years of insurance, gallbladder will be removed. 90% of people will have insurance. So I'm not really worried about the patient who has insurance. I'm very happy.
Any one episode of pancreatitis also is a contraindication. Do not start in them. Thank you.
Regarding the pancreatitis, if it was not a GLP-induced pancreatitis and the patient has been stable for over a year, calorie intake is good, but BMI is up beyond say 30, 35, can I not consider starting GLP-1 doing very slow dose titration like over 6 to 8 weeks?
If they have pancreatitis.
They've had a past history. But there was a gallstone, but that was removed post cholecystectomy. That was one case. Now the other case was he was a ethanolic. He had heavy alcohol intake. That scenario also I have seen. But it was not a GLP-induced pancreatitis. I've given it. I've not had an episode so far, and I'm doing extremely slow dose escalation. Over 6 weeks, 8 weeks, and baseline I've done an ultrasound. I've done my amylase, lipase. I do it month on month. I'm ensuring the other triggers of pancreatitis are not there. So triglycerides under control, quit alcohol. So can I use it? I mean,
Just take a written consent form because the patient should not go to pancreatitis with somebody else and tell that the doctor told me ಏನಿಲ್ಲ ಪರವಾಗಿಲ್ಲ ಸ್ಲೋ ಆಗಿ ಮಾಡ್ತೀನಿ ಆಗಲ್ಲ ಅಂತ ಹೇಳಿ. So there is a difference in how the statement is made. You tell that the risk of pancreatitis is there, but since your weight loss is more important for other problems, I am okay and you are also okay. No problem. Then the patient should start saying, the patient will also sir ಹಾಗಾದ್ರೆ ನಾನು ಕಮ್ಮಿ ತಗೊಂಡ್ರೆ pancreatitis ಆಗಲ್ವಾ? Your answer will be chances ತುಂಬ ಕಮ್ಮಿ. You will not say ಆಗಲ್ಲ. Then you say ಆಗಲ್ಲ ಇಲ್ಲ ನಿಮ್ಮ pancreatitis ಮುಂದೆ ಬರಲ್ಲ.
I don't
No,
understand.
sorry. You cannot say that you will never get pancreatitis.
Yes.
So you always tell that the risk of pancreatitis has been explained to the patient and hence he is still willing to continue. Please document that whenever
Yes.
you start.
I do that 100% for anybody who comes to me with a history of pancreatitis. So I just want to confirm that. Thank you.
I also had a recently similar patient who had a history of ethanol-induced alcohol-related pancreatitis a year back, and now he has stopped consuming alcohol. 1 year down the line, and at the baseline also it was a mild edematous interstitial pancreatitis, nothing necrotizing. And 1 year he was off alcohol, and now amylase, lipase are everything okay, and now he says that I'm not going to consume alcohol. So assessing the risk stratification, explaining it to the patient, and considering it as a non-recurring cause of pancreatitis, not like a familial hypertriglyceridemia. It's like an alcohol or a gallstone which was treated with cholecystectomy, then definitely we can give them the benefit with the proper consent. And yeah.
So usually, like sir, you said, I do wait till the end of 1 mg or 7.5. But a lot of these non-responders are also people non-adherent to the diet and exercise, sleep, working rotational night shifts. And they all want to then jump over to Tresopetide because they're reading about it. And I said, unless you work on your lifestyle, I'm not going to shift. Because suppose they don't work on their lifestyle. I'm still having someone who's working night shifts. I've failed on semaglutide. Should I still try Tresopetide or should I say, no, I want you to work on your lifestyle for a month before I switch over? What would you suggest?
He knows my answer. Shift to
So,
tirzepatide.
question related to what
Yes,
Madam
yes.
asked. Uh, I mean, I'm a gynecologist.
Please,
I
please.
usually send patients of PCOS and IVF. So, for how long do you wait? Because patients come to me asking will be started in semaglutide. So, initially, should we tell them that 30% of them are going to be non-responders, or you have any criteria where you know that these patients may be non-responders?
Correct.
Do you have anything like that? This patient may be a non-responder, so I will not wait for a long time, and because we will have other plans of IVF or
Correct.
treatment.
So there are some genetic markers for non-responders for GLP and tirzepatide which are not commercially available for usage. So for now we do not know which patient is going to respond, which patient is not going to respond. So probably you'll have to just put a word of caution that probably there's the other molecule tirzepatide obviously which is slightly like in terms of non-responders it's slightly better. And I think you'll have to just discuss and tell them that this is how it is going to happen. So if the stakes are very high, okay, if someone is going for a IVF or something, and you see a lot of like pregnancies postponed to even 30, 35 or something, 35, 40s also they're coming. Yesterday I asked one of my old patients, any plans of pregnancy? Then देखते हैं sir अगले साल. She's already 39. Then ठीक है, we just knock them off, nudge them कि ठीक है, plan it if at all you're planning it quite early at that. But then again, if the stakes are very high, I usually use the drugs which have less of non-responders and probably discuss with them. Only point, semaglutide is probably in terms of the cost which has come down recently. So that makes us tilt more towards semaglutide. In terms of weight per se, it is more of tirzepatide for me than semaglutide. If it's a long-term diabetes-related comorbidity management, ASCVD risk reduction, then it's more of semaglutide, so that the cost is also affordable, accessible, and other things, and we continue it for a longer duration of time. Just 1 milligram should help, and the sugars respond beautifully. Okay, if you just titrate it up to 1 milligram, I've seen insulin dose reduction even up to 30 to 40% also. And
This is only for obesity, which I'm asking,
yeah,
non-diabetic
yeah, I
patients.
understand. So then probably I'll discuss with the patient. So cost versus how things are going, but mostly the patients are so emotionally turmoiled and emotionally burdened that usually they are sort of someone who is going for IVF. Okay, they would definitely agree for they would definitely choose for tirzepatide over than that of semaglutide.
The dose of
90%
hormones
times.
which I give also will be increased.
Yes. Take care.
So
So
usually the non-responders are considered those who don't lose at least 5% in 3 to 6 months. So that is the basic clinical criteria. So if you calculate that at least 1 to 2%.
Can it be clubbed with bariatric surgery? Because many of them are above 35%, 35 BMI. So,
Yeah, so some of the patients are not fit for bariatric surgery. So they say the surgeon says that you are still not fit. The Manasika told that there is something. Then before preoperatively they have given many patients receive 3 to 6 months of therapy.
bariatric itself takes a long amount of time. There has to be psychological counseling, nutrition settlement, and all of that. So clearance for bariatric itself take a month, operate, and then for them to stabilize over some time, again it takes 6 months. And it's an invasive procedure, comes with its own comorbidities and other mortality risk also. So definitely, I feel taking a very invasive step like a bariatric would be too much for someone patient of this something like pregnancy at least. Like there, I'm not demeaning the value of pregnancy in a person's life, but definitely I would definitely discuss these things first and then move on to bariatric surgery in those who don't respond. What do you do, Rashmi, in such patients?
Yes, sir. Definitely, I would also like to consider regarding initial GLP-1 medications. Then, once they lose some sufficient amount of at least 5 to 10% of the weight, even 5% of the weight loss also leads to clinically meaningful cardiometabolic health benefits. Later, then we can refer to bariatric surgery.
For 5% weight loss, the response rate is more than 80-85%. For 10%, it comes down. So the 5 to 7% is achievable by these things. But the goal that we want is 10-15%. That the response rate is like this.
we send both the men, both of them, even for the husband semen parameters, we send them also.
Sometimes they take to the question.
Thank you, sir.
Thank you so much, Dr. Mahesh sir and Dr. Basavaraj sir, for this wonderful practical approach of setting up an obesity clinic. Thank you everyone for the patient hearing.
All right. Thank you, everyone. Thank you so much for joining us on day 2 of Disha. I hope everyone had a wonderful day as we did, and look forward to seeing you in future Disha sessions as well.